to be here, and I really mean it's great to be here. I will tell you that for the last 2 days, I'm part of President Killeen's Executive Leadership Program. And as part of that, we spend a week in DC, we spend a week at Urbana-Champaign, and a week at Springfield, and a week at UIC. So we get to experience all the campuses. And so this week we were down at Springfield. And I don't know if you've been watching the weather, but it's snowing in Springfield. And so I left at a good time, and it was snowing, but the roads weren't that bad. And I was like, oh, I'll be here in plenty of time. There's no issue. And then I'm going up 55, and next thing you know, Highway 55 is shut down. And so then they had us all do on this detour, and thank goodness for GPS, because I'm not sure where I would be right now. But that really seriously delayed me. And so I got here about 10-15 minutes ago. So it's great to be here because I really wanted to be part of today's events and the forum, because I think it really very nicely showcases the important work that's going on both within the School of Public Health and across several of the health sciences colleges around combating the opioid epidemic. And so I think you're really in for a treat tonight as we talk about the work that's going on. I do want to thank the Alumni Council for all of their great work and their great partners in terms of the Alumni Learning Series, but it's always a pleasure to work with the Alumni Council on all of this. And I also want to thank the staff in the Advancement Office for their work as well. So to kick things off, let me go ahead, and I think we have an extremely distinguished panel with us today, so I'll go ahead and kick it off and talk about sort of who is on the panel. And so to my immediate left is Dr. David Jimenez. He is the director of the Community Outreach Intervention Project, also known as COIP. It has 5 field offices throughout the city and a mobile unit. And COIP is battling Chicago's opioid epidemic on a number of fronts, including its long-standing needle exchange program, to HIV and hepatitis C counseling, to testing and case management, to drug counseling and recovery support. And COIP is really an amazing program that you'll hear a little bit about. To his left is Dr. Basmati Bodrum, Associate Professor of Community Health Sciences here at the School of Public Health. Her research sits at the intersection of substance abuse and infectious diseases. She currently has 2 NIH grants and 1 grant from CDC, one of which is a 5-year longitudinal study that will examine the role of social networks as they relate to drug use and adverse outcomes. The second study is the first of its kind that will use empirical data to develop a computational model to discover strategies to eliminate hepatitis C among individuals who inject drugs. And the third is to use an intervention to increase the linkages between hepatitis C treatment among Chicagoans. Basmati was also named this year the UIC Researcher of the Year. So congratulations. To her left is Dr. James Schwartz, Professor of Social Work at the Jane Addams College of Social Work. He is working with the Illinois Department of Human Services on 2 aspects of the opioid epidemic in Illinois, reducing the number of deaths from overdoses and gaining a better understanding of the epidemiology of addiction in the state of Illinois. He's working in 6 counties known to have high numbers of opioid-related overdoses, and he has been working on a project called Illinois' Prevent Prescription Drug and Opioid Overdose Deaths, which has increased the availability of naloxone reversal kits, as well as training individuals in their use. Next to his left is Dr. Todd Lee, professor and department head of pharmacy systems and outcomes and policies at the UIC College of Pharmacy. Dr. Lee's research focuses on patient outcomes from the use of medications with an interest both in safety and in cost and the intersection of these two disciplines. He is currently collaborating on a number of innovative projects with the Illinois Prescription Monitoring Program and the Centers for Disease Prevention, Centers for Disease Control and Prevention program for states to meet with individual providers and to change prescription patterns around opioid use. I think it's important as we do our work that we not only hear from researchers, but that we also hear from our students as well. And we see in our students each and every day the innovative work that's going on with our students. And so it's really a pleasure to introduce also Josh Smith, who is currently an MD student here at UIC. He is co-founder of Chicago Street Medicine, which has a goal to improve the health of the city's homeless through outreach, education, research, and advocacy. Many homeless, especially those that inject drugs, do not seek medical treatment, and Josh and his fellow students see themselves as a gateway between hospitals and extremely vulnerable populations. And I think what you will realize as you listen to Josh is that the future of public health with leaders such as him is going to be very, very bright. And so I think through the panel, I think you will see some really nice work showcasing the impact of the work that we have here at UIC. So how we're going to start the panel is that each of the panelists is going to show you a couple of slides highlighting his or her work. And then I'm going to have a series of questions for the panelists as well. So it looks like Dr. Jimenez, you're going to kick us off, is that right?
Yes, I will. All right. Thank you, Dean.
Sure.
My name is Dave Jimenez. I'm Director of Community Outreach Intervention Projects, as mentioned. I've been with COIP for 30 years, a little over 30 years. I was trained as a sociologist, got hired with this project in its beginnings as an ethnographer, and charged with overseeing the qualitative research that focused on one particular community in Chicago back in 1987. And I've stayed with the organization since then, and really have been really won and impressed by the nature of the work we do and the staff that I have. So I included in this first slide like an image of basically the type of work we do is really out in the community. It's people from the community, and it's targeting folks that really are at risk for initially HIV, but now substance use overdose. So in terms of like the origins of COIP, we were founded in 1986 by Dr. Wayne Weibel, who's emeritus faculty here in the School of Public Health, I believe, when he was awarded one of 5 original NIDA research grants that was funded to develop an intervention targeting substance-using injection drug users who are at risk for HIV. When Wayne applied for the funding, HIV was beginning to make a transition out of the gay community and into injection drug users, and so Wayne ended up developing this project, and it got funded. And the aims of the project were to evaluate the extent of HIV infection among injection drug users who were not in treatment, and to deliver and evaluate an HIV prevention intervention using the Indigenous Leader Outreach Model. The Indigenous Leader Outreach Model is an approach that we developed at the outset, and that we use through today. And I think it sort of what sets us apart, I think, from a lot of other programs and organizations around. Basically, we hire staff that are ex-substance users to go out in the community to do our work. And the benefits of hiring folks with these backgrounds are they're very knowledgeable about the life circumstances because they've been through it. They know the community. They're able to understand the cultural norms and patterns of folks that we're trying to reach. They know where to target the intervention. And so that was one really key aspect of this intervention that we ended up developing. I did want to add that this work is based on the earlier work of Patrick Hughes, who developed this model previous to Wayne to target heroin opioid epidemics in the 1960s. So we've kind of come full circle. We're using a model that was developed and initially identified in response to opioid outbreaks in the 1960s. And here we are again using the same characteristics and qualities of this model to work to target the opioid epidemic today. These are just some pictures, hopefully you can see clearly, of the types of locations where we do our work. As I said, one of the hallmarks of our intervention work is to actually reach people where they're at. Typically, people that are involved in substance use try to hide behaviors, or they're not, they're running from the police or law enforcement, or have some other issues, and so they're typically hard to find. But we end up focusing our intervention activities where folks are at. So that means we go into abandoned buildings, encampments where homeless IDUs may live, and other places like that. So, and typically when we go there, we're able to bring not just the HIV or opioid naloxone overdose prevention materials that they need, but other basic needs that people have. Food, clothing, we distribute those types of things as well in our work. Our overall mission, our prior director, Jerry Donnenberg, who's on the College of Medicine, ended up developing a strategic plan for our organization that we use through today. And we've identified 3 points to our mission: to produce knowledge, education, and provide services to improve the health of marginalized individuals and families in the communities that we target, to eliminate health disparities and improve access to health. We have 3 cornerstones to our program that kind of define the work that we do within QUIPE. There's a research component, there's a training and education component, and a service component. And here's some examples of the types of programs that are currently funded by QUIPE. We do targeted HIV and HCV testing, HIV Ryan White case management services, hepatitis C case management and testing. We have a soft tissue infection clinic that we recently began through funding through the Hearst Foundation. We have had for the last 15 years, maybe longer than that, a syringe exchange program that's been ongoing at 4 of our sites. We recently got funded by the state of Illinois substance use recovery program to do a recovery support program. We have been doing for the last 10 years opioid overdose prevention, education, and naloxone distribution. And we also have staff that recovery is part of their daily life, and so they volunteer to do NA support groups that we run at our field sites. So those are occasional. In terms of the student education and training, we've had a variety of students that participate in the work that we do as part of their research or educational experience. We've had Schweitzer Fellow. We've had School of Public Health students that have engaged in a number of different studies that are ongoing to help with data collection and analysis. We have students from exterior institutions like Governor State University and University of Wisconsin that have participated in some of our service programs to basically learn frontline service delivery work. And then we've had ongoing collaboration with the College of Medicine and College of Nursing to deliver, to provide students with a learning experience as we do outreach and work in these community settings, and also to allow them to help administer medical care in some of our grants that we And lastly, just a couple of opioid-related research initiatives that are ongoing. We recently completed a IDPH opioid data project, which helped develop, the state developed this data hub to be able to use opioid data more effectively throughout the state. We also, Dr. Larry Willett, who's a former director of COIP as well, directs the trends in drug use in Chicago component of COIP. COIP is a sentinel site for the, it's called NDUS, National Drug Emergency Warning System. And so he puts out a yearly report that kind of gives a snapshot of drug use in the city every year. I run the CDC National Behavioral Surveillance Program. I'm a co-investigator on that in collaboration with the Department of Health. And every 3 years, we do a surveillance of HIV among injection drug users, which provides important information. Last year, we ended up having some measures that looked at opioid use and overdose experience and fentanyl, exposure to fentanyl. And finally, we'll talk more about this, I guess, during the rest of this discussion. We're in the process of submitting a lot of applications in response to this epidemic. We'll have a chance to talk about that.
I should just go?
Yeah,
Okay.
just go ahead and go.
It's to the right.
What, you press this one?
Yep. There you go.
That's disconcerting to have like a big picture of yourself behind you. Let's get off of that one. Okay. So as Dean Giles said, I'm in the College of Social Work. I've been at this for 30 years too, over 30 years. So not enough time, and I don't think much interest in me going over that entire 30-year trajectory. So I'll focus on the most recent, which Dean Giles also mentioned, in that I'm working with the Illinois Department of Human Services, and most specifically the recently renamed Division of Substance Use Prevention and Recovery. They had been Division of Alcoholism and Substance Abuse for many years, and they renamed themselves to SUPER. So there's two projects that I'm heavily involved in. One is the one where 6 counties identified by SUPER as being at particularly high risk for opioid use, opioid overdose, and opioid-related overdose fatalities, were given money from the state through a grant from SAMHSA to increase the number of people who had access to naloxone, which is the drug that can rapidly reverse an overdose and help someone recover from it if they've overdosed, and provide training to people. So largely targeted by that initiative are first responders, and first responders primarily are police officers in most of these areas of the state where this project is occurring, but also bystanders. And bystanders can be anyone identified as being in an area where people are overdosing in any numbers. So sort of surprising, but in some cases it's first responders are they're training restaurant workers, they're training librarians, they're training people in places like that where for whatever reason drug users congregate and get access to drugs, and they're seeing numbers of overdoses. Well, that's the basic project. My role is as the evaluator. And one of the things I thought I could do to help them do the project was to collect all of the data that the state collects but keeps in separate places and doesn't ever look at it conjointly. So, for example, the Illinois Department of Public Health collects data on emergency medical services where ambulances go, and in some of their calls, quite a few of them actually, they administer naloxone. They are the first responders in many cases. And there's data on emergency department visits and hospitalizations. There's coroner's data on opioid overdoses and so on. That was all kept in separate pools, so one of the first things I did was try and aggregate all of this data, get access to it and aggregate it and start looking at it, and trying to help them hone their efforts in on where is this epidemic occurring most often, and getting down to a fairly granular level, as we'll see in a moment. So this first slide here is just two maps of the state, obviously. The slide on your left shows the number of opioid-related overdose fatalities in the state based on coroner's data. So the darker shades reflect a greater number of fatalities. And the issue with looking at just number of fatalities is that, by and large, it tends to track where there's more people. So you don't get a full picture of how prevalent throughout the state this problem is. And so to get around that, you look at rates. And the chart on your right is the rate of opioid overdose fatalities throughout the state. You can see that it's not really contained in high population areas. It's moved into all parts of the state, even in some of the rural areas, although the greater numbers continue to be in the more populous counties. I mentioned that we can get down to a fairly granular level, and this is a hotspot called hotspot analysis that we did for DuPage County, where we looked at their EMS data. They were interested in knowing where are the emergency medical services technicians going compared with where we're training people to administer naloxone. And you can see those bright orange areas indicate areas of greater activity. So the EMS techs are going there most often to administer the naloxone. And the way they're using this information is to adjust their trainings. So for example, in this area up here, it's just, I forget the name of that area, I think it's West Chicago. They hadn't done much training there. And so they said, oh, we better conduct some trainings and get the police involved and bystanders involved more in our efforts. So we're using the information to kind of target their efforts in a little more refined way. And the last piece I wanted to show them, you're actually getting a preview. Whoops, I got you up there. This is sort of a preview, not yet published data. One of the interesting things about this work is that as you do it, questions come up that you didn't think about when you started, and very interesting questions. So as I traveled around, excuse my voice, I'm getting over the flu. As I traveled around the state, listening to different communities and hearing people reflect back concerns, one of the interesting issues that people raised was this thought by a number of politicians that the Affordable Care Act actually may have exacerbated the opioid epidemic by making opioids more available to more people through prescriptions. And to my surprise, there wasn't a lot of hard data to support that. And so I thought, well, we have the information, let's take a look at it. And so the chart on the left, on your, on this side, the chart on that side is the number of morphine milligram equivalents. These are national data, by the way, but Illinois looks fairly similar. The number of morphine milligram equivalents by year, and the red line is the Affordable Care Act expansion states. The blue line is states that didn't expand Medicaid. And you can see that, yes, in fact, more morphine was made available in states that expanded Medicaid under the Affordable Care Act. There's no denying that, and it had to be because more people were getting access to drugs. But what was surprising about that was that that increase started well before the actual date of the full implementation of the ACA. So it started in 2011, 2012, and really peaked about 2014 when the ACA first started. The middle graph is the number of opioid fatalities due to any drug, and the graph over here is opioid fatalities due to prescription opioids. We would expect if the ACA had contributed to the opioid overdose epidemic that those graphs would look pretty similar. there is some similarity in the sense that the states that expanded do have slightly higher rates in both cases. But the issue is that these occurred much later than when opioids became more prevalent in the expansion states. When you combine this information statistically, you find almost no, in fact, non-significant relationship between the Affordable Care Act Medicaid expansion and the increase in opioids and the fatality levels in the states. The only way you can, and I'll stop after this, the only way you can posit a relationship is if there's some kind of lag effect, like a few years after perhaps people that started on a prescription then started using other drugs and overdosed. Can't rule that out, but I thought it was just a sort of a very interesting question and an example of how we can use these data to look at policy sort of issues of this level of complexity. Thanks.
Dr. Berger?
All right, we'll skip that as well. Although I kind of like it because it's like 10 years old and makes me look younger, so haven't bothered to update those photos. So not quite 30 years, but I did start this work in 1997 or so in New York City as the epidemiologist in the HIV division of the New York City Health Department after my master's program completion. And since then have come to UIC in 2002 and started to continue my work there with COIP as a graduate student. So I've also been here with David, and for a short period I was also COIP's operations director before becoming faculty. So yes, my work is at the intersection of substance misuse and mostly street drugs and primarily heroin injection and adverse health outcomes. Primarily I've been focusing on hepatitis C as one of my primary areas of interest. But just this is probably speaking to the choir and these already, but we are seeing these alarming increases parallel with the prescription drug misuse. We're also seeing that with heroin, and we're also seeing this parallel increases in hepatitis C incidence. There's a lot of people in the United States, 1.3 million or so, who inject drugs, which is the primary reservoir for hepatitis C infection. 70% of those new infections come out of this population. And we're seeing remarkable increases in the incidence in Hep C. So why this stuff now? So in terms of the trajectory, since I've been at UIC, at COIP, I've been embedded in the service and the research pieces of COIP since 2002, and I've been looking at a lot of data. Epidemiologists, that's what we do. We look at a lot of data. So with the syringe exchange program, you can see these just some shifts in demographic and geographic shifts in terms of the individuals who have been initiating into drug use. This is combined data set for about 6 years or so, where you can see on the whatever side you're looking at that says older, people who are in the older generation of injectors, those over 30, is what we're calling older. We're predominantly from urban environments and in non-Hispanic Black. So I'm not sure you can actually see the color, but the little blue is non-Hispanic Black, and the red star are non-Hispanic White, and the triangle yellow or Hispanic. So you can see there's a shift in the younger population where we start seeing a lot more injectors who are non-Hispanic White from the suburbs. So a total shift in terms of the population. So that is parallel with data that we see in studies across the country that's focused on young people. The first three bars are the CITES 1, 2, and 3, which are multi-city collaborative injection drug user study that were done by CDC from 1994, 1997, and 2002, the same study done across different cities. And you can see with those national samples, there's been, again, an increase in the proportion of individuals who are non-Hispanic White. And at COIP, data that came out of our studies, SAFCAP, Psych, and Social Network and Mood studies, more recently you're seeing just more of the same, except it's getting larger. So this is the population that's really piqued my interest in terms of like what does this shift mean and how it would affect sort of the epidemic. And we've been seeing this since 2002 when I got here, and well before I got here, we've been monitoring this. So, so trying to think about how this shift might have an impact. This is my dissertation work way back, where we see, if you just look at the CITES-3 data, which is done in 2002, what is the role of geography specifically in this population? If we focus strictly on young individuals, you'll see that if the two cities with the largest difference in hepatitis C, Baltimore and Chicago, that had predominantly white populations and mostly suburban, had really stark differences in hepatitis C. So again, why these are just some questions about what might be some of the issues that might drive these differences. There's a lot of things I can go into that. If you have questions about that particular study, I can talk about that more. But that's just sort of the background in terms of setting it up for what are some of those reasons that are driving these differences, that are geography, that are structural. We look at all the individual behaviors that people who inject drugs are doing, but we're not seeing the answers in those. So it brings me to the study that Dr. Giles mentioned. So we have a longitudinal study that we're going to follow 420 or so people. Before I get to that, we actually did a pilot study to get some preliminary information to see, well, maybe we can understand that. Out of that pilot study, we saw, when we identified this subgroup of young people who are highly transient, predominantly suburban born, but they're moving a lot back and forth in terms of residence between the urban and suburban area. And this is a group that engages in high-risk behaviors more than any other group. They are 5 times more likely to inject inside the drug markets, have a lot more sexual partners compared to their peers. So that's what preliminary data from the longitudinal study shows that we have 37 people so far that we followed in the largest study that's now ongoing. We're seeing out of this small sample so far, 76% already experience at least one overdose with a mean of 9 and a range of 1 to 40. So this is a population that's experiencing a lot of overdose. 54% have been hooked on prescription drugs, and they have much larger network size than we saw in our pilot work. So we're already seeing some increases in terms of risk in the profile from our pilot work in 2012 to 2014 to this study, which just started in 2018. So shifting a little bit to the other hat that I wear, we've been collecting all of this data for all of these years, and there's a lot of really great strategies for addressing the opioid epidemic. The question is, what are the combinations of those strategies, and what target populations do we need to do to impact opioid use disorders, hepatitis C, overdose? So computational modeling has been the other hat where we've been collaborating with multiple institutions, the FDA, and a lot of folks using empirical data to build realistic models so we can evaluate these types of questions to inform policy and interventions. I think that's all I wanted to say.
Thank you. I'm a little hesitant to change the slide because the dark background is a lot easier on my eyes, and I used a white background on my slide, so I know it's going to be terrible as soon as I change the slide. I think what's been evident so far from the work that we've heard about is the complexity of the opioid epidemic and the fact that it touches all kinds of different parts of the health system. I'm going to focus largely on prevention, trying to avoid the opioid epidemic. We've heard some about injection drug users and challenges amongst that population. I want to focus on some of the work that we've been doing in collaboration with the State of Illinois Prescription Monitoring Program to try and prevent opioid misuse and abuse. This work stems out of, as Dr. Giles mentioned, some funding from the Centers for Disease Control and Prevention called Prevention for States, where they identified a need to help states develop and implement tools to try and combat the opioid epidemic. This was launched a little more than 4 years ago, where 29 states were funded to try to develop interventions within those states that would change the way opioids were used within those states. So Illinois has taken on initiatives in a number of different areas, and we are involved in a number of these different initiatives. And for example, they're working with health systems to integrate the prescription monitoring program data with the electronic health record data to make it easier for healthcare providers to understand if their patients may demonstrate opioid diversion, or doctor shopping behaviors to potentially avoid prescribing in that patient population. We're also working on initiatives that focus on county health departments and providing them with tools and information that can be used to take to providers within those counties. But what I'm going to spend most of the rest of the time talking about is some intervention work we're doing focused on primary care providers, and that is trying to educate primary care providers about safe and appropriate use of opioids amongst patients with chronic non-cancer pain. And we've implemented some academic detailing initiatives to try to help to educate that provider group. And so I thought I'd just take a few moments to describe what academic detailing is. And academic detailing really grew out of the effective detailing that pharmaceutical manufacturers used to do to providers. Well, we've been able to, there's a large evidence base that shows that this one-on-one educational opportunities can modify prescriber behavior. And so we've leveraged what we know about these one-on-one interactions to provide evidence-based information about appropriate opioid prescribing to healthcare providers. We utilize specially trained detailers to go have visits with primary care providers talking about appropriate use of prescription opioids, as well as a number of different factors related to the opioid epidemic. And as I've said, there's a strong evidence base that this has been effective across a number of different issues that have been presented in the healthcare system, from HIV monitoring to appropriate blood pressure medications, and we're trying to implement this with respect to the opioid epidemic. So we've done academic detailing are doing academic detailing in two settings. We've completed an academic detailing initiative in some of the collar counties around Chicago, where we saw more than 180 providers over a 3-month period with these one-on-one academic detailing visits. But because of some of the information that James showed about geographic variation in some of the issues that exist across the state, we know that the message that we may need to deliver in urban settings is very different than what we need to deliver in rural settings. So we've launched another initiative that focuses on the southern part of the state. Initially, we were targeting the Delta region, which is the four rows of bottom counties in the state of Illinois, but we've expanded to the bottom 31 counties in the state to provide academic detailing to the primary care providers within those regions, because the issues that they experience is, again, substantially different from the issues that are experienced by providers around the Chicago region. We provide visits, again, on a one-on-one basis, where over 15 to 30 minutes, our trained academic detailers talk to the providers about the CDC prescribing guidelines. They provide information about their past opioid prescribing history. So we go in with information that compares the individual prescriber to a comparison group, either a health system that they belong to or the geographic region that they reside in, and let them know how they compare, not in a judgmental way, but just as we'd like to share information with you about your past opioid prescribing habits. And many of them are unaware of what their opioid prescribing patterns might look like over the last 6-month period. We then go back and see each of these providers 6 to 8 weeks later, where we tailor the information we provide in that subsequent visit to what they'd asked us about in this initial visit. So this is a really tailored intervention to the needs of the healthcare providers. I should not have animated this slide. I'll just quickly click through it, but this is the 12 points that are included in the CDC's opioid prescribing guidelines for chronic non-cancer pain, and currently we're focusing on the 6 of those points in red, where we're talking about the appropriate use of the prescription monitoring program as a tool to identify, again, potential opioid-seeking behavior amongst patients. We talk about naloxone, we talk about co-prescribing of benzodiazepines and opioids and the risk involved with co-prescribing. non-opioid therapies. We talk about starting at low doses of opioids and understanding issues like morphine milligram equivalents. So if I'm prescribing 2 different medications, or if I have a patient on 2 different medications, what's the relative potency of those 2 drugs, and provide the prescribers with tools to have available to them once we walk out the door. And just to give you a sense of, just to give you a sense of what we've done to date. Again, we saw 186 providers in the collar counties. They've had a tremendous amount of satisfaction with our visits. More than 90% of them said they were satisfied with our visits. And as an indicator of, I think, how engaged the providers were, we were able to see more than 85% of them a second time. These are busy primary care providers. We focused on general medicine, internal medicine, family practice, either physicians, PAs, or nurse practitioners, but they let us back in the door. They wanted to see our detailers again to have them provide information about, again, opioid prescribing and tools that they can have available to them. In general, they take 15 to 30 minutes of time, and we have this high level of satisfaction. We've currently seen more than 40 prescribers in the southern part of the state and are hoping to see an additional 50 to 60 before the end of April when our evaluation period kicks in. We're waiting for 1 more month to accrue to determine the effect of this academic detailing intervention in the Chicagoland region, when we've got 6 months of post data available to us to allow us to evaluate the effectiveness of this program. And I'll turn it over to Josh. I guess you don't need your slides.
No, thank you. Well, thank you. Yeah, my name is Josh Smith, as you can see, and I'm incredibly honored to be here, but for the sake of Dr. Lee's eyes, I will go relatively quickly through my slides. So as Dean Giles noted, I've been working with Chicago Street Medicine for about 3 years now. We're a collection of student-fueled street medicine organizations throughout Chicago, and we're dedicated, as Dean Giles noted, to improving the health of vulnerable populations with a particular emphasis on the unsheltered homeless through service, education, research, and advocacy. And we obviously chose those 4 pillars because, as has been noted and as has been emphasized on this panel, the opioid use disorder is incredibly complex, as is the chronic disorder of homelessness. So we mainly deal with the very, very downstream consequences of opioid use disorder and the opioid epidemic. A major reason that homelessness so complicates opioid use disorder and healthcare in general was described by Dr. Lillian Gelberg in 1997, where she published a paper called Competing Priorities that basically said, when you're struggling to maintain the basic necessities of day-to-day life, food, shelter, warmth, healthcare seems optional. So even though healthcare is very close to the base of the pyramid of needs, it's safety and security, homelessness, as I noted, is a daily physiologic struggle just to survive. So for many of our patients on the streets, going to the clinic or going to the hospital is optional. It's a secondary priority. So starting in 2016, we helped bring street medicine to Chicago, and we started bringing care to them. And the philosophy is we bring care to them on their terms and on their turf, because as Dr. Jimenez noted, that's the only way that the care is going to be recepted by very vulnerable populations. So here's a bunch of pictures of our team doing our work. Our work is obviously very multifaceted because the needs of our patient population is very multifaceted. So we hand out food and survival supplies. We do a lot of wound care. Obviously, just listening to patients is incredibly healing. And then evaluating medical concerns and triaging to the hospital if need be. We're very lucky. All of our student chapters are affiliated with academic institutions, and thus we can follow them through their inpatient stay, and that's how we act as a bridge between the streets, the healthcare system, and back to the streets to hopefully provide continuity of care. So we have a manuscript draft that we're currently working on that basically estimated that the cost of healthcare for the unsheltered homeless in Chicago annually is about $64 million. And data tells us that 80% of those care costs can be dealt with through adequate primary care. So that's what we're trying to do. We're trying to cut costs, and we're trying to help people on the streets where they are. So our team, our volunteers, our leadership, we are learning and training and working firsthand with the consequences of what is hopefully the peak of the opioid epidemic. And for better or for worse, it's given us quite the insight into human suffering and systemic failures. So I'm incredibly excited to be here and learn and discuss and find out from these researchers what the next steps are.
Great, thank you. Thank you, everyone. So I'm going to start with the first question. Several of you mentioned that you've been working on the epidemic for 30 plus years. Right, but there's all this attention now to the epidemic. So my first question is, what's changed? So why all the attention now? As we think about this, I think, Boz, you talked about sort of changing in terms of demographics, and I'm wondering if you think that is part of it, but are there other things as well that might be leading to sort of why we're seeing all this attention now to the epidemic, that sort of how this changed? And also as part of that, are there root causes that we need to be thinking about in terms of addressing the epidemic?
You want to go first?
No, it doesn't matter. No, the slides are there.
Okay, yeah, the slides are here. Sorry, we're getting our act together very publicly. Thank you. So I'm going to tell a story. I'm going to address the root causes part of that issue. Not that there's any single root cause. It's complex. The story that is told very often, repeated in the press and elsewhere, about the current opioid epidemic is that it really started when Purdue Pharma started aggressively marketing their new miracle drug, OxyContin, back in the mid-1990s, and aggressively going after physician groups, telling them that we're under-medicating pain in this country, and we have this new drug that has this time-release mechanism that will prevent people from or reduce the chances of getting addicted, and all that turned out not to be true. And prescription drugs were, and the number of prescription opioids increased dramatically over that period of time. It was a very successful campaign. And so a lot of the current, a lot of the thinking about the current epidemic is that it started then. And I want to argue that it actually, that was only one piece of the story. It certainly was a big contributing piece. But if we back up a little bit, I think we can see that it really added to a trend that was already starting back then. I'm not going to spend a lot of time way back when, but one of the things, for a period of time, back about 2009, 2012, I was working on a book on drug policy, and I was interested in this issue of why do certain drugs become popular at certain periods of time. Why was cocaine so popular in the where did that come from in the 1970s? And then heroin seemed to resurge. So I started doing some investigating of that for the book, and I came to believe that that political action and policies are relatively minor relative to larger social currents and contexts, and I still believe that actually. And so in the book, when I started talking about the current heroin epidemic, we go back to the development of heroin, which I don't know if you know the history of it or not, but this was developed by Bayer Corporation, the same company that makes Bayer aspirin today. It was marketed as a cough remedy, as a safe alternative to morphine. And that's true. It was marketed that way. So you can already see some parallels to the OxyContin marketing campaign. In fact, you see that occurring over and over and over again in our history, that a new drug comes out, it's marketed as safe, and then the potential for abuse only becomes apparent after it's in widespread use. Just parenthetically, I was reading today where ketamine is now going to be available as a nasal spray for depression, and they're saying it's safe, and I go, okay, we'll see. I'm a little skeptical, but we'll see. Maybe it is. So anyway, heroin could be purchased over the counter for a number of years until people got wise to the fact that it wasn't safe, and so it went underground for a long time. But there were certainly multiple heroin epidemics, and in more recent history, the Vietnam War and vets returning from Vietnam who had been addicted to heroin while serving on duty, heroin sold to them, in fact, under the auspices of the South Korean or the South Vietnamese government that they were there fighting for, was also marketing heroin to U.S. soldiers. It's what led Nixon to declare the first war on drugs in 1970 and led to the Controlled Substances Act that's behind our scheduling of drugs now, that's still in effect today. Okay? So we had that heroin epidemic, subsided to a point, then flash forward now to the 1990s, where I'm going to sort of place the current epidemic starting prior to the Purdue Pharma campaign. Some of you are old enough, and some of you aren't, to remember this ad campaign by Calvin Klein. This was called the Heroin Chic campaign, where they had models who looked like, at least they had been using heroin, and it was marketed as sort of a desirable kind of chic look. And none other than Bill Clinton got in the act of criticizing them for marketing their product in this particular way, as if drug abuse, heroin use was somehow glamorous. But heroin was, in fact, making a comeback at that point already. And I know that because at the time, this is from 1988 to 1995 or so, I was doing research at a company called TAS, Treatment Alternatives for Safe Communities. And we were part of a national project called the Arrestee Drug Abuse Monitoring Project, that every quarter took urine samples from 250 arrestees at the Cook County Jail and tested them for drugs. And what we were seeing back then, the top line is cocaine, which was certainly more prevalent, but we were also seeing about 20 to 30% of the people coming in to the Cook County Jail were testing positive for opioids, and primarily that was heroin. So we already knew that heroin was back. And not only was it back, but it was different than the heroin from the 1970s. It was much purer. It was, if you seized a bag, the DEA would report statistics like, if you seized a bag of heroin in the 1990s, you might find that about 20 to 30% of it was heroin. The rest of it was filler. That's as opposed to the 1970s and earlier, when it may be about 1 to 5% pure heroin. And the point of that is that you could reach a broader market with the heroin. People could get high by snorting it now instead of injecting it. So it broadened, the drug dealers did this very intentionally to broaden the market. And it wasn't just any drug dealers, it was South American drug dealers. Prior to this time, most of the heroin in this country would come from Southeast and Southwest Asia. But the cocaine traffickers decided in the 90s that they wanted to diversify their drug trade. So in Colombia, they started growing poppies, and they started producing heroin. And this is from the drug threat assessment by the DEA, which shows that over time, the amount of drugs, the amount of heroin seized in the United States became predominantly from Colombia and Mexico. And it was the influx of this pure, highly available, relatively cheap heroin that I submit to you contributed largely to the current epidemic. When Purdue Pharma came along, this was already in motion, and they added fuel to the fire by bringing in a lot more people through the prescription opioid channel who, over time, either because the prescription opioids were too expensive, and sort of ironically, prescription opioids became the gateway drugs to heroin. You saw all of that together fueling this epidemic. So I think you need to know this backstory in order to know the full story. And just very quickly, Dean Giles, what's different now is and I think this is common knowledge, that the drug supply is increasingly being synthetic opioids are increasingly being used in the drug supply. So primarily fentanyl and analog drugs like fentanyl, which are much more potent. Those are certainly what's driving. I missed the slide I wanted to include, but I could show you that the recent increase in opioid-related deaths is largely attributable to the increase in fentanyl in the drug supply. And not just heroin. Fentanyl is being used to cut all kinds of drugs. It's being pressed in pills like ecstasy, and it's even being pressed into counterfeit versions of OxyContin. And so that's my answer to the question of why now is it so important. It's this increase in fatalities due to these highly potent drugs. That's my story.
Thank you.
There's one more slide you got to just pass through.
No?
Sorry, I missed one.
Do you want to?
This was just a story that came out. This is the event of OxyContin, which was called Hillbilly Heroin. So it just added to the end of the story. Go ahead.
Thanks. So, when I approached this question, I wasn't really thinking about the root causes. I'm glad you gave really a nice historical perspective on that. I was thinking about the work that, we do in COIP, and that it's really mostly street focused, so we're really talking about street drugs that are out there. And I ended up talking with some field staff that are frontline working on the syringe exchange and doing the naloxone work, and then thinking about our own research that Baz and Larry Willett and other folks have done over the years. And I came up with a couple of things that I thought to me reflect what's been obvious to us is like the big change over the last 10 to 15 years. And the first has to do with a point James kind of pointed to, that heroin use has grown, but has recently been eclipsed by fentanyl as the most available opioid in Chicago. To kind of look at some indicators, ended up looking at some of the data that's collected through the community epidemiology work group that Lawrence Willett authors. As I said earlier, Chicago is one of the sentinel sites around the nation, and we collect that data to get a snapshot of what drugs are out there on the street and the quality of them, what the costs are, and the availability. Anyway, I looked at a report from 2005 and compared it with a more recent report in 2015. And back in the mid-2000s, heroin and cocaine were pretty much equally abused in Chicago. There were some emergency room mentioned data that show that they were the top two drugs that were most reported in 2003 and 2004. In 2004, the number of patients in public-funded treatment programs were pretty much equal among users of both. Early on, though, we were getting some data back then on heroin's impact on mortality, overdose deaths. I found some data in that report that said after reporting one death per year in 2000 and 2001 due to heroin, the Chicago Department of Health reported 18 by 2002. And in 2003, there was a new data collection monitoring system that was used, and they reported 27 heroin-related deaths in the Chicago area. Now, by 2015, you begin to see the real impact that we're talking about here. Health indicators showed heroin to be the most abused street drug in Chicago. Use of heroin was the most frequently reported reason for seeking drug treatment, representing about a third of all people looking for drug treatment. And it was involved in 81% of the 426 opioid-related deaths in Chicago. So you've seen just looking at mortality, the number has been dramatically increased over the last couple of years. This next slide I just added to give you an idea back in 2015 of the deaths that were attributed to heroin versus fentanyl. And back in 2015, heroin was about 81% of all the heroin-related deaths, overdose deaths. The other interesting thing is right around 2014, you begin to hear more information about fentanyl through the drug testing lab reports from the National Federal Lab Information System, which collects and monitors quality of drugs that are seized by local police, state police, and federal police. And to show you an indication of dramatic rise in the number of samples that were reports of fentanyl, In 2014, there were 21 reports, but by 2016, there were over 1,000. So, another way that we've noticed that the epidemic has evolved is that more and more you hear about it in suburban areas and areas outside of Chicago. There have always been some substance use back through the 90s that we've known about, but just the proportion, the percentage of it, is just a lot. There's just a lot more reporting about it. I give some data here for Will County and DuPage County as examples, looking at the increase in deaths over the last between 2014 and 2016. The other point I want to I show on this slide is that the problems have become so critical that local law enforcement and jurisdictions have tried to develop systems to respond to it. So, for example, in DuPage, they instituted a Narcan program to train their law enforcement officers on how to administer it, and they actually have a website now to provide information to residents in the community that are interested. A couple of years ago, I reached out to a family member that began an organization that is doing opioid support support groups for family members who have other family members that have died from opioid abuse. So there's a lot of these kind of grassroots organizations that are forming to raise awareness about opioid abuse in suburban areas. This last slide I added because there were some other things that we've noticed that I wanted to mention. One is, although there have always been homeless folks in over the 30 years that we've done our work, they're just a lot more visible for whatever reason. Our staff at our needle exchange report that the number of individuals that come in to use services that are homeless has just increased substantially over the last several years. And for anyone that drives in Chicago and comes in on the Eisenhower Expressway, from through downtown, you'll notice sometimes in the morning, rush hour, at every second corner, there's someone panhandling, and many of those folks are using, because we see them at our needle exchange. Another thing that we've noticed, and Josh alluded to this, is the prevalence of soft tissue infections. We've noticed among the people that use our needle exchange that a lot more are having really bad skin infections, open wounds, and needing help to treat that. Another thing that we've noticed is that some injectors, particularly younger injectors, may be adapting more riskier behaviors because of the conditions of their skin where it's hard to find a vein to inject. Some folks have reported using longer syringes. So when we distribute naloxone, we hand out a special syringe which is longer, and some people actually want those to be able to inject to access a deeper vein. So it's just a lot riskier injection going on among a subsample of folks that we reach. Then the last thing is kind of less tangible, but the older injectors that come to use our services as well as staff have talked about newer injectors as being a different group, more marginalized, less ties to the community, more transient, a lot more risky, and just so that's one thing for us that's been noticeable.
So I don't have too much more to add to a lot of what has been said, but yeah, dovetailing on, we have always seen the younger, predominantly non-Hispanic white injectors being riskier to begin with, and they just haven't been within the context of the background or the structural features that promote, sort of overdose or transmission of hepatitis C and things like that. But the transient population that we've been following is really large, and it is coming out of the suburbs, so they are moving back and forth a lot. So it's not just an urban population; it's predominantly suburban folks who are losing their ties much faster as they transition. In qualitative interviews with young folks, I feel like I've seen a faster transition from like softer drugs and from prescription drugs to heroin and to harder drugs. So I think we're seeing that as well. And I probably shouldn't say this because I'm not the sociologist on this panel, but there are probably a lot of reasons for, why that might be. And if Larry were here, we'd have some chats about, this is not a community that's been devastated by the HIV epidemic related to injection drug use, so they didn't have that social memory of what that looks like. Injection drug use is highly stigmatized in African American communities. So now, and so as it's just didn't have, these kids don't have that memory of like what that impact on their communities are. So it's been a faster, more experimental transition into other drugs again, and they're battling the media and all of the other things, right? So they're a different group in general. But if I want to think a little bit more about some of the structural things that might be different as this population has shifted to outside of the urban environments. I put up the slide from CITES way back in 2002, where we looked at Chicago versus Baltimore, and we saw this, after controlling for all of these differences in behaviors in the same study, we had the lowest incidence of hepatitis C compared to Baltimore, which had the same population, everything being equal. And so I started looking like more into what was going on geographically, and you would see like things like if you map the residence of people where the population was, the syringe exchange program was not. You had Baltimore suburban or urban white populations, but you had the syringe exchange programs in African American neighborhoods. Go think about all of those things that might prohibit and be barriers to going to those and access and using. And the syringe exchange program participants in Baltimore were actually a lot more riskier than the ones in Chicago. So it's two different populations, right? And things like, fewer resources in non-urban environments. So we've experienced lots of epidemics with heroin and drug use in urban environments. We have infrastructure, harm reduction, more MAT and things like that. So I think part of a lot more impact in broader impact is a broader population that doesn't have access to a lot of resources that are embedded in urban communities. I think that's probably it.
Giles, can I make a point? I don't have slides. I don't dispute what James said about an underlying growth of heroin during the early to mid 90s, but I don't think that the healthcare community gets a free pass in this one. I think that there's clear evidence that the opioid epidemic that we're in now started with prescription opioids. Like, you see the mortality rates in this current epidemic, those were largely related to prescription opioids before 2015 or 2016, when we start to see the major growth in heroin and fentanyl. So the healthcare community had a role in this. And part of it was Purdue Pharma's activities and marketing OxyContin and the maybe unscrupulous way in which OxyContin was marketed. But there were other factors at play. There was the fact, and perhaps the manufacturers had some role in this, but there was pain being considered the fifth vital sign, right? That was a major initiative in the mid-90s when healthcare providers were being trained. It's unethical to think about having patients in pain, because pain is this fifth vital sign, and that certainly led to some increased willingness to prescribe prescription opioids. And in many ways, that does serve as the pathway drug, the initial medication that leads people on the road to opioid use disorder, which leads to all of these downstream consequences that the other panelists have talked about. So I think the healthcare community still has a major responsibility in trying to curb this epidemic, because we were there when it started.
I remember when I got my lawrence home, I got a 30-day supply of narcotics, right? I think that's a great example, but the dentist was so concerned about pain, I got a 30-day supply, right?
Yep.
The impact of
Yep.
that. So thanks for bringing that up.
I also think there's been like just a general cultural shift in terms of how we've perceived self-medication. I mean, I remember seeing the first advertisement for a depression drug in my generation, and that was like, whoa. And then it was perfectly acceptable to medicate for anything, really. So it wasn't the stigma associated with, so it's beyond pain. There's just a broader cultural shift in terms of acceptability of self-medication.
So, Ken, I'd like to pivot a little bit from shifting epidemic, et cetera, root causes to someone could talk a little bit about sort of potential interventions. I don't know who wants to take it.
I'll start. So let me see, is this,
Yeah.
Yeah, this is it.
there we go.
Next one, yeah.
So, you know, when I saw that question, I was thinking of like what the character, you know, we have some proposals that are ongoing that we'll talk about, I think, as well this evening. But what I wanted to approach with this question was what I thought were the essential kind of characteristics of an intervention to deal with folks on the street, which we, you know, who we target primarily. And I came up with this list here. The first is that, you know, I think any intervention that's going to be targeting folks that are using opioids need to provide opioid prevention, education, and naloxone distribution, because we know, at least from our work, that individuals cycle in and out of addiction and recovery. You know, people that with the best intents to stop using may stop for a while, but then something will happen, will trigger them to use again. The other, you know, so that's one reason why I think it's important to include that focus. Another characteristic that I think is based on our own work, and I'm biased because of this, is I think you need to focus active users where they're at. The point that Josh raised earlier is our model, our approach, that we reach people at the locations where they're injecting, where they're living, where they congregate, because we think that's the most effective way to reach folks, where you get the most bang for your buck. So I gave some examples here: syringe exchange programs, incorporating street outreach programs in any intervention. ERs actually are a good location to reach folks, and I know of a couple of interventions that are happening in ERs that are doing soft handoffs into treatment. Another bias I have is I believe you need to use peers to deliver these interventions, at least parts of these interventions, because of their own personal lived experience, the legitimacy that they can give to an intervention based on their lived experience and knowledge of the community. We also believe that you need to have a more holistic approach when delivering an intervention, because aside from an intervention that's targeting the specific addiction issue a person has or risk a person has, the folks that we reach tend to have a lot of other social needs: clothing, housing, food, transportation, IDs, a lot of basic things that people need to help addressing before they can proceed. And then finally, I have there addressing the issue of stigma. One of the constant issues that get raised by folks that we work with are the idea that people that are delivering interventions or working in substance abuse feels unnecessarily understand their issues and have biases toward their treatment, not just within substance abuse fields, but within the medical field as well. So I think any intervention needs to kind of address that issue. So.
Other comments?
Go ahead.
You mentioned building a wall. I thought that was supposed to keep all the drugs.
Right. That to me doesn't. I don't think that's an effective way to use federal funds to deal with the opioid epidemic. I mean, you know, I was talking with someone about that this morning, and it's just a waste of money in my perspective. I mean, what do you think about it, Paul?
About 30, at least 30 years ago, I was visiting DEA headquarters, I guess it was in Virginia, and they had a motorcycle that one of the international motorcycle gangs like Angel shipped in, I think from Australia. And what they had done, the rubber tubing in the engine
Oh.
had been put together where the cocaine was like right in the rubber, cocaine sniffing dogs, the smell was right there in the rubber. But when the motorcycle got here to this country, they could just dip that tubing in the solvent and the cocaine would separate out from the rubber.
So, Boss, you have a comment?
Does anybody else want to?
About?
And I just had, so just dovetailing a little bit on with what David has mentioned, again, you know, we're dealing with addiction here, right? So it's not an easy problem, and people need some help, and all of the approaches that David mentioned need to be embedded into all of interventions that we develop. But we need to understand that there is a need for specific, you know, regardless of whether or not it's a disease like hepatitis C or an opioid use disorder or overdose, what are the sort of cascade of care or trajectory or continuum, and we need to think about what kind of strategies we need to use, and case management and using peer models and things like that have to be part of the solution. So one of the things we've done at COIP with CDC funding is to develop some of those strategies, and we hope to implement them into other applications that we've used, that we're applying for, that we can talk about later. That's really all I have.
And Dr. Lee, I guess you had also mentioned some of the work you had done around physician detailing and monitoring prescriptions. I guess that's part of it.
For sure. I mean, and there's a ton of policy initiatives that are being put in place to, I guess, on the prevention side of the equation. On the treatment side, you know, there's certainly need for, we're undersupplied in terms of number of healthcare providers that are ex-waivered or able to provide substance use treatment with Suboxone or buprenorphine. So we need more of that. You know, that's one element. This is so complex and needs to have so many elements included in it. The fact that we have policy initiatives around requirements to check the prescription monitoring program, I think, is a help, right? It starts to move us in the right direction. There are policies in place to limit the number of days supply of an opioid dispensing. So now, Dean Giles, you would not be able to get 30 days for extractions of your teeth, right? You're going to be limited to a 7-day supply initially, and hopefully taken together, all of these things fill out essentially a fire hose of interventions that we can spray onto this epidemic.
I wanted to go after Todd this time. There's a number of things, as I've gone around studying what people are doing around the state, there's a number of different initiatives. There's no one answer, right, I mean, to this. And one of the things that people have been trying to do with the naloxone, it's clear, is to expand the number of points at which a person could get it, right? So you can go to the pharmacy, the police will have it, you can have it yourself, your friends can have it. So expanding the number of intervention points. At the same time, people have realized that naloxone certainly isn't the answer. It's really just let's keep people alive until we can get them into treatment, hopefully. And so that the idea of using that moment of an overdose to start to talk with someone about the possibility of getting into treatment, what they call warm handoffs. So a person is brought to the emergency room after an overdose, and there's a person present in the emergency room that would be available to talk with them about what treatment options they might have. They've expanded that, so even in Lake County, for example, they have a program called Safe Passage, where you can go to the police station, bring in your drugs, and no questions asked, there's a person there to help you try and get into treatment. So expanding the places where people can get into treatment and at least have that discussion is one of the things that's being done, in addition to the naloxone. There are some interesting new developments drug-wise. One of the things is extended release buprenorphine, which is an opioid agonist, which instead of having to take it every day, I think it's a 30-day effect. That's not been widely studied yet, but it would seem like it might improve adherence if you don't have to have the person taking that drug every day, but if it's effective for 30 days, that might get them further along. There is also, although I'm not as big a proponent of this, extended release naltrexone. It's being marketed as Vivitrol. Vivitrol is an antagonist. It's a slower acting naloxone, essentially, but it extends over time. So what it does is it blocks the effects. So if you take heroin while you're on naltrexone, you won't experience the effects. The reason I'm not as big a proponent of that is I think people don't like those drugs as much, the antagonists, and they stop taking them. So I don't think it has as much promise as a drug like buprenorphine. And then in addition, David and we've been slowly approaching this, the idea of giving people the ability to test their drug supply for fentanyl. There's fentanyl strips that are available. They're made in Canada. They're for criminal justice purpose, but you can buy them and distribute, and people are distributing them in Chicago already to users. There's potential issues with them. They're a little bit tricky to read, one, and two, we don't know this yet, so we want to pilot it. We're concerned that it might actually encourage some people, oh, this has fentanyl, okay, good, that's what I want. So we don't know the extent to which that might happen or not. But we're interested in giving people the information that the drugs that they're using contain fentanyl in it, and to take precautions then. To use less, to make sure that someone's around with you while you're using, and so on, to take other precautionary measures. So those are some of the newer things that we're looking at in terms of prevention, intervention.
Josh, did you want to say anything?
Yeah, so a few things. Obviously, a lot has been said, so my multifaceted mind is running. But to the point on buprenorphine, there was a JAMA opinion piece about a year and a half ago where an emergency department physician was her thesis was, I can prescribe all the opioids I want, but I have to jump through all these hoops to prescribe an opioid treatment. So even with a waiver, you can only have a panel of 100 to 300 patients on buprenorphine. So one thing that we've done is we've partnered with the departments of internal medicine, emergency medicine, family medicine, and psychiatry, and we're running a semesterly buprenorphine waiver program. It's an 8-hour course, but if you don't spoon feed residents who are working 20 hours a day, they're not going to take it. So that's one thing we're doing. But then to speak to the ingenuity of drug dealers and drug traffickers, they have an incentive, a very clear incentive, to get people as high as possible for the cheapest price. And that's why fentanyl and carfentanil are so dire. These are drugs that are orders of magnitude more powerful than morphine. So we had a patient about 8 months ago. They got hit with 8 vials of Narcan, and they didn't come out. That's unbelievable. But the policies that we are promoting, I don't want to say they encourage it, but they definitely condone this behavior because those dealers are making money because it's a lot cheaper to get people a lot more high because they're not selling heroin, they're selling the high. So, yeah, I think it's, and then the point going way back, just pain is incredibly complicated, and we don't fully understand pain, and I think that's why it was such a travesty 15 years ago that pain was the 5th vital sign, because heart rate is very objective and pain is not. And I think a huge rise in substance use disorder is a reflection of a societal pain in our younger generations, and we need to start asking, of course we need to treat these people who are already using these substances and self-medicating, as Dr. Basmati said, but we need to ask ourselves what is causing this and how do we as healthcare professionals address it.
That's good. So we've heard a lot about what's happening at the state level and sort of potential solutions. I want to sort of take us now to the national level and sort of thinking about sort of potential solutions. And so one of the leaders on this is actually the senior senator from Illinois, Senator Durbin, and his chief of staff is here with us tonight, Claricel Duque. And so if she would come on up, steps are right here, and talk a little bit about what the senator has proposed, we would be appreciative.
Good evening. Again, my name is Claricel Duque, and I am Senator Durbin's Chicago Chief of Staff. It's a pleasure to be here with you tonight. Thank you, Dean Giles, for the invitation to say a few words about what Senator Durbin has been doing on this issue. I also want to thank the panel of experts. I've learned so much this evening, and I'm excited to continue to work with the School of Public Health on this issue. I certainly want to commend you on the multi-strategy approach that UIC has taken to combat the opioid epidemic. Similarly, Senator Durbin has taken an all-hands-on-deck approach to tackle this crisis. There are many reasons why we've gotten to this place, as has been covered this evening. So we require work across numerous sectors and with many stakeholders to get us out. First, the pharmaceutical industry's misleading marketing and flooding the market with painkillers. In 2016, 14 billion opioid doses were produced in the United States, enough for every adult in America to have a one-month prescription. To address this issue, Senator Durbin has passed legislation to lower the DEA-approved production quotas, which for 2019 are now 45% lower for oxycodone and hydrocodone than they were in 2016. Second, the medical profession must embrace the latest understanding of opioids and practice responsible opioid prescribing. 4 out of 5 new heroin users started with a prescription painkiller. I'm thrilled to hear about UIC's efforts to responsibly reduce prescribing practices. Senator Durbin has worked with Illinois medical societies to adopt the latest knowledge and training on responsible pain prescription management, while also pushing insurance companies to stop making it easy to get a 30-day script of OxyContin rather than non-opioid pain therapy. Additionally, Senator Durbin has worked to expand access to naloxone and addiction treatment. He has fought to dramatically increase funding. In the current spending bill, there is a $4.4 billion funding for the opioid-related programs. This is the highest it's ever been. Senator Durbin also has led the fight to lift an arcane Medicaid barrier known as the IMD exclusion, which restricted Medicaid funding for treatment facilities with 16 beds or less. In the height of the nation's worst ever addiction epidemic, this is obviously very outdated and insufficient. Finally, I want to spend just a minute to talk about the work that Senator Durbin has done to address some of the individual level root factors that may lead someone to misuse opioids. One area that he's focused on has been childhood trauma. This is basic prevention. Studies show that exposure to 4 or more ACEs, or adverse childhood experiences, make an individual 10 times more likely to use heroin. Senator Durbin has been a leading voice in Congress to make our federal grant programs reflect an understanding of childhood trauma. So with the federal dollars, we can better identify and support those who have experienced early life adversity. We know that Senator Durbin, I can point to an experience that he had going back a number of years ago where he went to visit some of the youth at the juvenile detention center here, not too far from earlier today, where he learned that of the youth that were either awaiting trial or there at the juvenile detention center, 82% of them had either been a victim of violent crime themselves or had witnessed violent crime. So the senator has taken great measures to work on childhood trauma, and we believe that this is one of the root causes. So I want to thank you for having me here tonight. Again, I appreciate the work that UIC has been doing to address the opioid crisis, and our office and Senator Durbin looks forward to working with you. Thank you.
Thank the senator for his leadership. We really appreciate that. I think what we'll do is why don't we open things up for questions? There's a mic here for our panelists if people have questions. I'm sure the panel will be happy to answer any questions you have. If somebody comes in.
Thank you for having this panel. It's great. Just a couple questions about I saw the demographic shift in heroin use graph was really interesting. I was wondering if you looked at it in terms of if you had removed all the people who were introduced to, who became addicted as a result of prescription opioids, how would that shift look like ethnically?
If you removed everyone
Who became addicted through opioid prescription? Would we see that say? I mean, I'm just trying to get at were the white addicts predominantly from that group.
right. So in the current study that we're running right now, we do see that about 56% of those individuals were previously or currently also hooked on prescription drugs. So it is a large proportion. We didn't really collect that data with the pilot study in as much detail, so I don't have that information in as much detail, but we're definitely seeing a large group. There's definitely an overlap, one's fueling the other, but as others can attest, there's a lot of people who are going straight to heroin too. It's not, it's just that there's 10 million people who are misusing prescription drugs, so they're just contributing even a small proportion of that transitioning, was like 3 to 4% or so is an estimate into heroin use. It's a large group.
Just a quick question about pain. So what is pain considered now in the sort of in a clinical sense? Is it it's not the fifth symptom anymore?
No, that used to be a quality measure. Like the Joint Commission for Hospital Accreditation would penalize hospitals if they weren't measuring pain as the fifth vital sign. That transition has kind of gone away, where it's not considered the fifth vital sign anymore, largely I think as a consequence of where we're at today. It's still an important issue to consider for patients, but I think the importance now is understanding the cause of the pain and treating the cause of the pain. If it's musculoskeletal or some nerve-related pain, they have other alternatives besides opioids to manage that kind of pain.
That was the point I was going to make, and I think the CDC has some really nice guidelines around pain management that I think are important. And so, things like using non-steroidal anti-inflammatory medications for pain management is important. I also, I think one of the things we forget about, I used to run the arthritis program, and physical activity, simply walking, can have a huge impact in terms of pain. And so I know people want to take a pill, but I'm a firm believer that that pill, in fact, can be something like walking, and people getting more active. And I think we need to change some of that mindset. But really, it's about sort of how do we do a better job effectively managing pain. Next question.
Yeah, along the same lines of the changing demographics then to a younger non-urban population, how does that influence how we then reach them in terms of intervention and treatment and even preventing through education or outreach efforts to get them from preventing them from starting?
I can start with that. Well, the good news is that they're coming to us. So I think Chicago is unique in terms of the heroin outdoor markets, and there's a convergence of what's going on in those markets in terms of people buying. They're also injecting. They're taking up residents in these areas. They're coming into syringe exchange programs. We happen to be in those locations. So in terms of reaching them and delivering interventions, we have geography sort of at our to help us. In terms of other things that we could do as urban centers that have this experience, COIP has been around since '86. We've all been doing this work. We can use those skills and expertise and help develop things that could be meaningful and useful to other counties that don't have that infrastructure. And that's one of the things I've been working on is the case management model I talked about. We've developed that into a telehealth model where we can train people on the front lines in different areas using those types of features to help get them all ramped up to deliver interventions. That model is already in place using echo-based strategies for other diseases that we're using as models. So we can certainly do those types of things to reach the population or train the communities or work directly. I know this is a time for us to say we've actually submitted a grant to use this intervention in sort of a criminal justice population, working with 4 jails and the Illinois Department of Corrections as individuals are transitioning out of those communities. So as part of that model, we're working that outward that way.
So we've got 6 people,
Oh,
a
gosh.
lot of people have questions. So what I'd like to do, if you could ask your question quickly and the panel respond relatively quickly, that
Got
would be
it.
great. And the panelists will be available afterwards as well. Yeah.
No more demographic questions.
All right, I'll be quick. So in recent elections and upcoming elections, the hot button has been the opioid epidemic. How do you feel that cannabis, medical cannabis, might be another strategic way to reduce the opioid epidemic? Thank you.
I can only speak personally. I'm a proponent. I mean, it's certainly an option that would be available to use as another thing for pain. So I think there's some data, I'm not sure, from Colorado, right, that shows that it actually has had an effect, a positive effect in terms of reducing opioid problems. So I would be in favor of, broadening its use in Illinois.
I'm with James. I think it's an option.
Next question.
Hi, I'm from the Lake County Health Department, and I am part of the Lake County Opioid Initiative Committee, and we would love to have data, like you have shown us from other counties, about EMS response and their reporting. And I would love to get that from you, or know how to get that from you, because we've been having issues. A way out we know is working. We know that the officers they have all those numbers, but we're not getting them from EMS. And so I would like to know how to go about that.
I know Martin. I forget Martin's last name.
Clancy.
Martin Clancy. Yeah, and he's on the same project.
Yep.
And I have Lake County data, so you can just contact me
All right.
directly, and
got it.
I'd be happy to do it. Now, there's issues with the EMS reporting, so I'm not sure how good it is for Lake County, but we can certainly take a look at it. It's a relatively easy thing for me to isolate your data and present it back to you. No, I'd be happy to do that.
Beautiful.
So
Thank
guys
you.
need to connect after this. Perfect.
Absolutely. Thank you.
Next question.
Well, I know you were addressing street issues before and the gangs. It's my understanding there are fewer large gangs than they used to be, and a lot more small gangs that just operate on 1 or 2 blocks. And I'm wondering how big a problem is that with respect to the opioid distribution? I mean, heroin is one thing, but
Yeah, I agree with your assessment about the nature of gangs, a lot of smaller street gangs, but clearly they are, at least from what I hear from my staff, responsible for the organization of distribution in the city of Chicago. So there's still, an important issue to consider in terms of addressing, the availability of opioids. So our staff, we do kind of tangentially related. A lot of the outreach work we do is based on targeting congregation sites. Very often they overlap with the drug distribution locations. So for us, it's an important focal point because we know people will be there. But you're right. I agree with your observation.
Hi, my question is, what are your thoughts on the fact that Purdue Pharma also manufactures a buprenorphine patch?
Sure, there's some conflict of interest there. That's my thoughts.
It was an arsonist inventing a new fire extinguisher. It was one of my favorite things that I've ever seen.
Hi, Joan Weaver, Chicago Department of Public Health Administrator, the Office of Violence Prevention, Trauma-Informed, and Opioid Epidemic and Substance Use Disorder. And I'm so grateful to be in the audience to hear about the street homeless program and the medical van that you do have. I'm not even aware of that, and we haven't met with you at all, but I invite you to come to the Department of Health and explain the project more thoroughly, and meet Dr. Arwadi and our Commissioner, Julie Moretti, who I felt committed to come to the mic and say that the City of Chicago has an EPI report online with all the EPI data from 2017 that our epidemiologists assisted in doing, and we're right now able to hire 2 more EPI people to work on additional data related to the opioid epidemic and harm reduction and prevention, which we are working closely with the CRA van. Not to talk too much, I'd like to jump on to the other areas, and this report is online for anyone to look up and see on the cityofchicago.org/health website. We also have, in the areas of targeted outreach to make change in Chicago, we certainly like to thank Dr. Todd here, because we're right with you in the fact that our legislative department and our commissioner pushed forward legislation in Chicago, which is only the second city besides, or the first city really, but besides Washington, D.C., to pass a city ordinance whereby the pharmaceutical representatives who go around, and they are called pharmaceutical representatives in Illinois, who promote and sell and market medication at the doctor's offices, have to obtain a license in the city of Chicago if they practice 15 days or more. And they must take educational courses online, which are on our website and approved through our offices. And that also reaps a license fee back each year to the city of Chicago. And we, of course, back at the health department, are able to expand and enhance our medication-assisted treatment, which we have in the last year and a half. We expanded from not only delegates, but going out and providing waiver training and medication-assisted treatment through the 3 medications that are available, of course. And like you said, the most frequently used and more acceptable has been methadone, but then we've gone into the buprenorphine, and then the naltrexone, which is the Vivitrol, which has not been proven yet and gone through research. So that licensure, I think, is a great outreach thing that was accomplished in the way of the prongs of reaching not only the medical offices and providers, but the pharmaceutical industry, and then reaping back that money for treatment dollars to expand throughout the city. And we invite you to come, Dr. Schwartz, because you have helped me many times in the past with our RFP reviews. And it's nice to hear about what you're doing with our HIV department, Mr. Jimenez? Jimenez? However, so.
What we'll do is we'll connect Josh with Dr. Maria.
Right.
Will that work?
And right, yes. And I just want to bring forth that in the city of Chicago, the deaths on the streets of Chicago brought forward statistics that showed that the deaths in Chicago were African-American males mainly. 77% were males, the balance females. They were between the ages of 45 to 64. And they were also came, the majority, from Chicago. Very few were from outside the area. Of course, there was the same things you mentioned, the fentanyl with carfentanil and analogs of that fentanyl. In addition to only, really in comparison, only 11% had opioid pain relievers in their blood system from the studies that were done at the coroner's office. Sorry? But I'm so glad to hear from all of you, too, about the rest of the state.
All right, just a couple quick comments. As a family medicine doctor, we, over on the west side, we are not being taught that pain is the 5th vital sign anymore in medical school, nor in residency. And then I also wanted to just say that in the hospital, it's another thing that we're doing is starting Suboxone induction while patients are admitted in the hospital. So kind of that similar warm handoff concept in the emergency room. We're also doing that when patients are admitted in the hospital. For Josh, the Chicago Street Medicine, are you, when you are seeing patients where they're staying, are you also helping them get connected to MAT programs as part of like the comprehensive care for them?
Yeah, so it obviously depends on what they're ready for. We don't push anything and we let our patients take the lead.
Yeah.
Most of the success we've had, actually, I took a note as you were talking, has been induction in the hospital.
Awesome.
You know, somebody gets osteo and we come and bring them in and they're sitting there for a few weeks at a time. Our most recent success, he was in the hospital and he says if he hadn't been induced in the hospital on methadone and connected with a methadone outpatient provider that he could seamlessly transition to, that he would have jumped right back in because his SRO wasn't ready for a week. So he went back to the streets for a week and he was clean because he was ready and because the hospital was willing and able to do what he needed to get to what healthy meant for him.
Awesome. Great. The last quick thing is, do any of you know in the future who's going to be looking at the data and statistics from at opioid deaths in comparison to like when MAT treatment has been expanded and started? I presume it's the IDPH. Do you know if any other organizations are going to be focusing that, or has that already started? It might be too early. I don't know.
Not aware.
Somebody will.
Yes. Yeah.
All right. Thank you all. I want to thank the panelists. This has been a fantastic panel. So thank you for your work, your dedication. It really shows how nicely USC is doing in terms of combating the epidemic, and we're all grateful for that. And I would say the citizens of Illinois are grateful as well for your work. So if we could give the panel a hand.